All right, welcome to the podcast. Glad you're in with us today. So what we're going to be talking about is acute pain and spinal mechanisms and chemical mediators of acute pain and all sorts of fun stuff like that. I am Jay Grider. I run the pain program. Many of you have not met me yet. I look forward to meeting you. But let's dive into what we're talking about today. I guess this is a disclaimer slide that we have here. So what we're going to do is we're going to discuss the mechanisms of pain transmission, spinal mechanisms, acute to chronic pain transition, and some of the pharmacologic mechanisms of the chemical mediators that we're going to discuss that sometimes show up on boards. So as we talk about pain, there are really three broad examples. There is mechanical pain or nociceptive pain. And mechanical pain is really joint, muscle, ligament, bone, anything that moves along a hinge or moves via the musculoskeletal system is going to give you mechanical pain. So a shoulder, a knee, a hip, that sort of thing. Then there's also neuropathic pain, which is described as burning, shooting, stabbing, electrical type sensations. And then there's actually a third group of pain that has come to the forefront, which is inflammatory mediated pain, which has its roots very similar to mechanical type pain, but it's more of a global type of thing, sort of like some of the inflammatory arthropathies and that sort of thing. So we have mechanical pain and neuropathic pain, which are very different, and then inflammatory pain, which does sort of overlap in some ways. Now, some of the terms that you need to know, and I always hit on these in every lecture that we do because they show up and people tend to forget about them and not do well. Allodynia is pain out of proportion to stimulus input. So the way to think about that is lightly stroking skin should not be interpreted as painful, but oftentimes it is. So if a normally non-painful stimulus is painful, then that is allodynia. Dysesthesia is an abnormal sensation, so the sensation that bugs are crawling on your skin, or that that there is something on fire, or like your foot is down in boiling oil, that would be a dysesthesia. It's a non-physiologic symptom that is painful. And then hyperalgesia, which has really two terms. There's a localized hyperalgesia that is just part of the pain response. And then there's a chemically mediated hyperalgesia that we'll talk about that is often associated with opiates. Hyperalgesia is just pain out of proportion to stimulus input, which that's also the definition for chronic pain, which is pain out of proportion to stimulus input. Now, as I was talking just a few moments ago, in the broad classifications, mechanical pain is tissue destruction. Inflammation really has become its own, so I probably should have updated this slide, my apologies. But somatic pain, ligaments, joints, muscles, tendons, and also visceral pain that is expanded. So if there's a bowel obstruction, or or like whenever the uterus is expanded with hysteroscopy and that sort of thing, you get a pain that is mechanical in nature. So the mechanical receptors are activated and a painful stimulus is applied. Whereas neuropathic pain is nerve destruction. Neuroma. What is a neuroma? Whenever a nerve gets cut, the two disjointed ends seek to rejoin. And so they sprout in different directions, and those nerve endings that sprout are painful. And so whenever a nerve is trying to regenerate itself, if there's been a complete axonotmesis, or meaning a cut of the axon, then the sprout that grows is a neuroma, and it can spontaneously fire and be painful, or can be overly sensitive to non-painful stimulus typically. Radicular pain is the pain patterns that go in a dermatomal fashion. So whenever there's a nerve root compression at L5, pain down the outside of the leg to the top of the foot is pain in a radicular referred pattern. Now, we also talk about pain being referred in non-dermatomal patterns, which are like sclerotomal pain patterns, And muscles also have their own way of generating pain signals, which are myotomal pain patterns. So there are radicular pain patterns, myotomal pain patterns, and then sclerotomal pain patterns. Then we also have sympathetically mediated pain. So the complex regional pain syndromes have their feed-forward loops and have a forward feedback mechanism that we'll take a look at here in just a few minutes. Now, as we look at I'm a little thrown here because I don't know why the click it title and that stuff is on there. My apologies about that. So I'll try not to be thrown. But the anatomy of the nerve itself is important to understand, and it's become more important as regional anesthesiologists as we have learned some very shocking things. Now, I do have a lecture about regional anesthesia complications, which oftentimes is quite surprising to people, but let me just introduce you to a few basic concepts. So whenever you have a nerve, you have the outer portion of the outer epineurial sheath. The way to think of this is if you can picture paper towels from your kitchen. Whenever you buy them in the grocery store, they have a plastic wrap around them that holds the tissue paper together so it doesn't unravel in the store. And so that outer epineurial sheath is the plastic that holds the tissue paper together. And so then the inner epineurium would be like the tissue paper, sort of soft and pliable and sort of in sheets. And so the outer epineurial sheath and then the inner epineurium, which is the blue here, are really just ways of holding together the fascicles. The fascicles are where the nerve axons live. So then in each fascicle there's a perineurium that has endoneurium and then axons inside of it. So the way to think about this is the outer portion of the paper towel is the plastic that holds it together. Then there's this cushiony tissue paper type tissue that goes around each of the axons, and then the cardboard tube that's in the middle of the paper towel would be the perineurium that holds the axons in there. So if you put spaghetti down inside that cardboard tube, they would be the axons, held together by a very firm perineurium. So just a preview of coming attractions, whenever we do an intraneuronal injection, we can go through this outer epineurial sheath and into the blue epineurium and blow that up and not cause neuropathy. With some of the new research that's been done, it's only whenever we get inside the fascicle that it's thought now that we end up getting some neuropathy. So, and this has been shown with work by Bigaleson and other folks that picked up on that by ASRA. ASRA just had a whole special edition on block neuropathy, which I suggested every resident, everybody who's doing regional anesthesia should read that. But the latest data suggests that many of our injections for decades have been intraneuronal. We just didn't realize it. And it's only whenever we get inside the fascicle that you truly begin to get problems. So that's why this anatomy, which I'll be honest, I didn't pay much attention to whenever I was a resident, has become very important because as the science and the clinical practice has evolved, we need to understand the different layers of the nerve and how they play a part in overall clinical syndromes that we have. So we can inject that epineurial sheath or that outer epineurium, which we used to say anything inside the nerve was a problem. Turns out probably a lot of our paresthesia techniques, you didn't even get paresthesia until you got down inside the facet, or until you got down inside the epineurium itself. So a lot of our blind blocks that were done for decades were likely intraneuronal, unbeknownst to us. So that's why the anatomy of the peripheral nerve itself is very important. Now, also we have spinal canal anatomy, which you need to understand. So let's take a look at this. So we have 7 cervical vertebral structures. We have 12 thoracic and then 5 lumbar, obviously. So the spinal nerves actually exit above the level of the of the vertebral body in the cervical spine, and then it transitions in the thoracic spine, where they are at or below the level of the vertebral body from there on down. What is often not appreciated, and I try to talk about whenever residents rotate through over in the clinic, is the cervical spine extends fairly far down into the upper portion of the thorax, and the lumbar spine extends relatively higher up into the thorax than you would perceive. So we think of the thoracic spine, because it's 12 bones, as being this really long segment, whenever in fact it's surprisingly compact in most people, and that's because of the kyphotic curve that you have here. So one of the things that I try to do with every resident, if I possibly can do it, is when they come in to watch a lumbar epidural steroid injection, is to point out to them that what you think of as T12 is often much higher in the anatomy of the back than residents perceive that it would be. And so a lot of times whenever you are picking out what you think is T12, it's really more down around L1, L2, L3. And that's been a real common thing that I have observed. So whenever I was teaching residents how to do epidurals back whenever I was running the acute pain service, I would often tell them, go higher, and they would look at me like I was a crazy person. And partially that's probably because I might be, but it also had to do with the fact that you needed to go a little higher in the thoracic spine in order to make those epidurals work. Because what's an amazing thing is, if you put an epidural at the correct mesodermal level, you will need little or no patient-controlled bolusing. So a 2 or 3 cc infusion will pretty much keep a person completely comfortable without the need for bolusing. Bolusing is really an effort to push volume higher or lower for a catheter tip that is not in the right place. Whenever you get that catheter tip in the exact right spot, they will pretty much run a 2 cc infusion and not need anything else. All right, so on over to the spinal anatomy. This is the vertebral body. The vertebral body creates a kidney bean-shaped recess that has fat around it. So the epidural space is highly endowed with fat, and as a result of that, is highly vascular. So the epidural space is actually fairly resistant to infection, but it is highly vascular. These are the nerve roots. So you have the posterior nerve root and the anterior nerve roots that come together to form the large nerve root. This is the dorsal root ganglion, which sets in the nerve foramen. The nerve foramen is the exit that the nerve takes. Now, it should be noted that the nerve foramen is actually about 4 times larger than the nerve itself. So this pictures it as being very compact, but in the lumbar spine, you have quite a bit of space in the nerve foramen. So a disc herniation has to be fairly significant in order to cause neuroforaminal compression. You have the gray and white rami communicantes, which go out into this sympathetic chain. Sympathetic chain sits on the outer portion of the vertebral body on the anterior lateral surface. This is the lamina, and this is the spinous process coming out here. Okay. Now, excuse me, I'm sure you enjoyed that. I'll look inside my bronchial tree. A little bit more for you there. So each of the vertebral segments fit together with a facet joint, and each facet joint has a dual architecture. There is one posterior facing facet joint, so this superior articulating process here is posterior facing, and this one is anterior facing. So whenever you have a retro or anterior listhesis, which is a movement of the spinal vertebrae, one versus the other, there's always a gapping of facet joints. So if you have an anterior listhesis here, this bone has moved forward, this facet joint gaps, which creates facet arthropathy here, and this facet joint crushes the anterior process below. and so you develop facet arthropathy in these areas. So that's a key with an anterior listhesis, which is a forward slippage of a vertebrae. They fit together in this fashion, as you see on the lateral side. Something called a pars defect is between the facets is whenever there's a non-union of this area here, pars interarticularis, which is also a very common source of an anterior listhesis. This is the disc. You have the nucleus pulposus and the annulus. The annulus is a rubbery material that holds the soft nuclear material together. The nucleus pulposus itself is highly endowed with arachidonic acid mediated components, and so whenever it leaks out onto the nerve root, it causes inflammation, which is sort of a bad design, if you ask me, that you put something that is highly inflammatory and highly neuroirritant very close to neural structures. I love this Dell computer that I got. It keeps popping things up on me. If anybody wants a Dell computer, I'm going to throw this one away. So it'll be in the trash can sometime tomorrow. It's probably not actually true, but anyway. So here we have what would be the view of say an MRI. These are the spinal segments. These are the disc segments. And this is the spinal cord. So this is exactly what we see in cartoon fashion when we look at an MRI. And the spinal canal in the cervical spine is actually fairly tight. C5, C6 is the most common place for disc herniation to have spinal compression. Now, it's not the most common level to have disc herniation. It's just that the spinal, there is an enlargement of the cervical spinal cord as the nerve roots begin to exit out of the segment for the arms, and because there's an enlargement of that cervical spinal cord, any impingement into that spinal canal will cause spinal cord compression because the spinal cord is enlarged in this area. And so that's the most common place for there to be a disc herniation is C5-6. Now, whenever we do spinal analgesia, this is kind of complicated. Spinal analgesia has two components. When we're talking about opiates and medications like ketamine and that sort of thing, which you really shouldn't use in the spinal canal, but we have here at UK for decades. Medications in the spinal canal work in the dorsal horn, but local anesthetics work by anesthetizing the nerve rootlets. So local anesthetics don't actually penetrate the dorsal horn of the spinal cord and numb up the spinal cord itself. It actually works out here in the rootlet area that cause segmental analgesia by working here on these rootlets. This is probably more of a pain fellow issue, but the radicular blood supply is a big issue right now because of particulate injection of steroids. So just suffice it to say and to note that there's a big controversy right now about epidural steroid injections in particular. That's kind of ironic, I just said that. Particulate matter in particular is one of the issues. So if you've ever seen the depomethylprednisolone or betamethasone that are used for injection, it is a depot formulation that releases slowly over about 3 to 4 weeks, but it's particles like a snow globe. So if you ever can picture a snow globe being shaken up, that's what the material that we inject for epidural steroid injections is like. It's floating in a suspension. And that particular steroid, whenever it gets in these little small arteries, can cause spinal cord infarctions. Not so much with translaminar injections, but with transforaminal injections. So injecting out here at the root level, it's a lot more vascular. But even translaminar epidural steroid injections, though rare, have been associated on occasion with spinal cord infarction due to particulate matter. There's a big debate going on right now about whether epidural steroid injections should even be done, an FDA warning, and that sort of thing. I only discuss the vascular anatomy with you to point that out. Now, as you're working on epidural skills, you will find that most of your attendings are going to teach you a midline approach. And they're very afraid of something called the paramedian approach. The paramedian approach, as this cartoon represents, is just something that takes the spinous process out of play. So I'm going to go back 2 slides. If you were to anesthetize a spot here and place your needle up on the lamina here and walk in to the midline here, that would be a paramedian approach, rather than palpating the spinous process and trying to go in at this level. So as you can see, in the thoracic spine, as the spinous process does hang down over the, does hang down over the interlaminar space, you can work in paramedian and eliminate the spinous process from your deal there. And so what I found whenever I was doing thoracic epidurals was about 60% of the time I would convert to paramedian. So I just quit doing midline altogether, and because I thought, well, the residents need to learn that skill and so on. But it seems to be something of a concern. People act like, you know, a paramedian approach is kind of voodoo, and really all you do for the voodoo, I suppose, is you find the interlaminar space by palpating in between the spinous processes. I usually go directly over, and this 10-degree angle that you see here, anesthetize about a ½ centimeter over, and virtually go straight in. I walk off lamina. On occasion, you do have to walk off lamina. So if you walk continuously off lamina, you can get so flat that then you hit the lamina above. But it's really a sweet technique, and it's something that you need to learn and think about. So push your attendings to teach you paramedian approaches. All right, so back on to sensory neuroanatomy. Whenever we have the spinal cord dorsal horn, the dorsal horn is divided up into 10 segments called rexid lamina. So these are lamina 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. These lamina have specific histologic differences, and so they are really designated by histology. Different fiber types will synapse in these different lamina. From a pain standpoint, the ones that are important are lamina 1, 2, and 5. Lamina 1, 2, and 5. Okay? The A delta fibers synapse on lamina 1, 2, and 5, and the C fibers, as noted here, will impinge on level 1, and that's where the mu receptors are. So mu receptors modify sensory input from the periphery on lamina 1, 2, and 5. The mu2 receptors in the dorsal horn of the spinal cord are on lamina 1, 2, and 5. I keep saying that. The mu receptors are on lamina 1, 2, and 5. The reason why I say that is because it is important. It does show up on your test. So all the fiber types enter into the dorsal horn through something called Lasauer's tract. So that is out in this area. Lasauer's tract comes in, and then the fibers synapse on lamina 1, 2, and 5. Lamina 3 and 4 are where the proprioceptors and mechanoreceptors synapse. That'll be important in just a minute. Now, as we look at fiber types as they come in, so this is the primary axon coming in from the periphery. It synapses in the dorsal horn, and then it crosses over. That crossing over is called decussation. It crosses over and goes up in the lateral spinothalamic tracts, the paleo and neospinothalamic tract. Paleospinothalamic tract, meaning older, paleo meaning older, or diet, or if you're a CrossFitter, that kind of thing. The paleospinothalamic tract carries more rudimentary pain information, whereas the neospinothalamic tract carries more fine-tuned and more evolved pain signals, I suppose would be the way of saying it. And so they carry up in the paleo and neospinothalamic tracts in the lateral aspect of the spinal cord up to the midbrain, the medulla, and the thalamus, where they synapse at the thalamus. Now, it is in this area that you impinge on the reticular activating system, and then from there at the thalamus, you have projections out into the cortex, the amygdala, the hippocampus. It is mu2 receptors which, excuse me, my goodness, I had pneumonia 3 weeks ago, and I don't seem to be getting over it. I guess it's just getting old. But anyway, so mu2 receptors do impinge, are present here in the dorsal horn of the spinal cord, and they modulate spinal input from the periphery. So you may have heard the lecture that I did for the ITE, but I'll use this example. If 1,000 pain signals per second come in from the periphery, and there's nothing going on modulating function here at the dorsal horn, 1,000 pain signals will then cross over and go up to the brain. Now, at the brain, application of opiates into the periaqueductal gray and the ventrorostal nucleus will disassociate the pain sensation from the amygdala, the hippocampus, and the other higher cortex centers. So in that sense, we are decoupling the sensation from the emotional centers of the brain. So whenever you apply opiates into the higher centers, the amygdala, the hippocampus, the periaqueductal gray, the ventrorostal nucleus, you stop the projections over to the amygdala, the hippocampus, and the emotional centers of the brain. So we're really uncoupling the sensation of pain from suffering. And that is a key tenet of chronic pain, is that what you're treating in chronic pain is suffering. The sensation of pain may or may not be debilitating, but it is the effect on the emotional centers that play a big role in what we ultimately end up treating. From an acute pain standpoint, really what we want to do is modulate either the sensory input from the periphery via nerve blocks or adjunctive medications, or modulate the pain signals here at the dorsal horn of the spinal cord. So if we apply morphine-like drugs into the interthecal space, 1,000 pain signals come in. Morphine is an inhibitory neurotransmitter or an inhibitory agonist. So if 1,000 pain signals come in, and we apply morphine here on presynaptically and I suppose postsynaptically, depending on your research bent, then 700 signals would go up. You dampen the pain signal just by applying morphine here, or you apply local anesthetic to the peripheral nerve or local anesthetic to the rootlets, and you stop the pain transmission from coming through and getting up to the brain, and you also begin to inhibit wind-up, which goes on here at the spinal cord. So, whenever you activate pain fibers, there are really two types of pain fibers. There are the A deltas, which are fast, and the C fibers, which are slow. So let's pretend like you're using a hammer on and you hit your thumb. The fast immediate pain that is sharp is A delta mediated, and then that slow throb that begins to take place, that is C fiber mediated. Now, any anesthesiologist worth his salt has at some point chased C fiber pain in the operating room. The most common place to do that is tourniquet pain. So over time the tourniquet is on and blood pressure starts to increase, heart rate starts to increase, and no matter how much opiate you apply to the system, you don't block that C fiber response, and then whenever you release the tourniquet and the sensation is gone, you can't wake your patient up. That's happened to every anesthesia resident since time began, and it's happened to you. Just go ahead and admit it. And you just didn't call your attending. You waited 40 minutes in the operating room, and boy, they must have been sleepy. They're breathing about 2 times a minute, and so. So that's the difference between C fiber and slow mediated pain and A delta pain. But what is unknown by most people, or it's not unknown, it's just poorly appreciated, is that there are projections from one type of fiber over to the other. Okay, so the A beta fibers, which are mechanoreceptors, can actually inhibit these C fibers, which are nociceptors. Why do I tell you that? Well, because whenever you hit your thumb and that thumb is hurting, what do? You grab it and you rub it. You activate mechanoreceptors from a touch standpoint and from a motion standpoint, and proprioceptors. So mechanoreceptors are activated and proprioceptors are activated, and by doing so, these interneurons at the dorsal horn go from mechanoreceptors, these A beta mechanoreceptors, to form an inhibitory influence on the nociceptors. It dampens the signal by activating the mechanoreceptors. So by doing that, you inhibit the nociceptors of these C fibers. This is the gate control theory of pain. If you hit your thumb and just stand there and look at it and scream, you get every ounce of the pain signal going up to the brain. But if you grab the thumb and activate the mechanoreceptors, the touch receptors, and move the thumb, activating the proprioceptors, you begin to close that gate off. Now, the interneuronal contact also has some other weird things. Have you ever noticed that even though you have an area of a cut, you might be sore for several centimeters away from that injury? This is the concept of primary hyperalgesia, where there is an injury and that C fiber will send signals to its cousins that are close by, activating the nociceptors that are close to but not directly involved in an area of an injury. So here a C fiber is connecting over via interneurons over to another C fiber a distance away, creating an area of primary pain or primary hyperalgesia, and then an area of soreness or secondary hyperalgesia out in the periphery. This is a way of helping us to understand that we have an injured area and not to keep aggravating it. So it's interesting that our nociceptors talk to each other to tell them that they're experiencing an area of pain. So that whenever you get injured, you don't just have this small band of injury. It communicates a wider protection. Now, that's a protective mechanism whenever you first get injured, but if this starts to set up and continues on after the injury is healed, then this is not a very effective system. You've actually developed a system that makes you dysfunctional. So in this case, we're talking about hyperalgesia as an area of hypersensitivity beyond the area of pain because of the primary injury. Here's a non-injured area that is also experiencing pain, but it is a protective mechanism. So this is a physiologic form of hyperalgesia that is somewhat beneficial. Other types of hyperalgesia that we'll talk about later on are mechanisms that end up causing where chemically we induce an increased state of pain. So this is a slide that I had in our previous discussions. Here you have an area of injury. You have the C fiber nociceptor being activated. It goes into a wide dynamic range neuron. What is a wide dynamic range neuron? A wide dynamic range neuron takes a variety of inputs. Pain inputs, proprioceptive inputs, mechanoreceptor inputs, and it sends all that up to the brain. Okay? So we have signal convergence. We have pain signals and mechanoreceptor signals all converging on a wide dynamic range neuron. Now, only so much information can be hardwired to be sent up to the brain. So if 1,000 pain signals per second come in from this injury, and the wide dynamic range neuron is activated only with pain signals, 1,000 pain signals will go up to the brain. But if we grab the thumb and rub the thumb and activate the mechanoreceptors, that wide dynamic range neuron is the switchboard operator, which tells you which signals are going to go up. And so if 1,000 pain signals are coming in and 1,000 mechanoreceptor signals are coming in, the wide dynamic range neuron says, I want to send an accurate representation of what is going on out in the periphery up to the brain. But in order to do that, I can't send 1,000 of each. I'm just not hardwired to do that. But I'll send 500 of each up, and then I will tell them, hey, there's a lot of injury and a lot of mechano and proprioceptor activation going on out there in the periphery. And by doing so, you actually dampen the signal. That is the gate control theory of pain. 1,000 pain signals come in, 1,000 mechanoreceptor signals come in. The wide dynamic range neuron says I can't do 2,000, but I can do 1,000. I'll do 500 of each. And so the intensity of the injury is dampened by the mechanoreceptor activation, which is the gate control theory of pain. You also start to see here projections from the anterior portions of the dorsal horn do form and send out to the sympathetic ganglion and then back out to the periphery. So you can begin to get this feed forward mechanism where the wide dynamic range neuron gets fired up and activated, activating sympathetically mediated fibers, causing changes out in the periphery, like swelling, temperature change, color change, sweating. Potential unwanted program is blocked. Thank you for letting me know this every 30 seconds. And these sympathetic fibers then begin to activate and have a feed-forward mechanism going on their own, and that is complex regional pain syndrome. That's sympathetically mediated pain, which is a subset of spinal cord activation in facilitated segment, meaning that the spinal cord is firing on its own. It is a facilitated segment. And that is what I'm talking about here whenever I say that this can become a spontaneous mechanism that is feeding forward, both getting information from the periphery and then feeding out from the spinal cord after the injury heals back out to the periphery, making the region look abnormal because of blood flow abnormalities, because of pseudomotor sweating abnormalities, and allodynia, dysesthesias, even though the injury has healed. Okay. So what are the chemical mediators whenever we get a lesion? So we get a lesion on the periphery, we get things like bradykinin. Bradykinin is a strong mediator of inflammation. Bradykinin 1, bradykinin 2 is actually a intercellular second messenger, but bradykinin 1 receptors are often inducible and related to the inflammatory response. Prostaglandins, potassium is released, histamine, substance P, mast cells rush into the area and degranulate, releasing histamine. Substance P activates blood vessel changes. So there's all sorts of neural factors that are released into an area that create this feed forward mechanism of inflammation. Now, when inflammation starts to spread on its own, well, then you begin to get a setup where you also have this spontaneously feed forward mechanism, and that used to be thought of as mechanical pain, but now we know that the body can just continue these inflammatory states. Some people are just pro-inflammatory, and that's not a personality disorder, although I do believe it might be in some. But the inflammation that they form just continues on and on. I see this all the time in the chronic pain clinic. So I give somebody an epidural steroid injection, and one person will get 120 days out of it. Somebody else gets 6 days out of it. And they, in their mind, think of it as their problem is just worse. And so you look at the MRI, and a lot of times the severity of the MRI has nothing to do with the response to the epidural steroid injection or the facet injection. What is different is the way that the patient creates inflammation. And so what I tell people is your response is unknowable. People that I have looked at and said this person is not going to do well with this injection have gotten 3 and 4 and 5 months out of it. And people that I thought this is going to be a slam dunk only get a few days, and that has to do with, I think, their internal chemical mechanisms and their ability to form inflammation. All right, well, we are now 40 minutes in. I'm going to give you a break, and we will stop this. This will be the March 7th lecture on anatomy and the chemical mediators of pain. Thanks a lot, and I appreciate it.